What's up, Ninja Nerds? In this video today, we're going to be talking about hypercoagulable states, also known as thrombophilia. Again, this is part of our clinical medicine section. If you guys like these videos, they make sense to you, they help you, please support us. You can do it a couple different ways. Hit the like button, comment down in the comment section, subscribe. Also, go down in the description box below. There's a link to our website. On that website, we'll have tons of things that can help you throughout your academic journey. Things like notes, quiz banks, we have illustrations, and so much more. So go check that out. But let's get into hypercoagulable states. All right, my friends. So when we talk about the pathophysiology of hypercoagulable states, it kind of really begs the point of why are we discussing this concept of Virchow's triad? Well, if you remember, Virchow's triad was the triad that determines the risk of thrombosis, and that's dependent upon stasis of blood flow, endothelial injury, and hypercoagulable state. So not only can hypercoagulable states increase the risk of a thrombosis within a vein or artery, but so can stasis and endothelial injury. So it's important to just have a quick recap of, again, what is stasis? It's kind of where the blood is stagnant and it increases the time for platelet binding to the endothelium. So that's really the kind of concept here, is it increases the time, for platelet binding to endothelium. So for example, as blood is stagnant, you have more time, especially if the platelets are moving through here, to be able to stick to the endothelium. And if these platelets stick to that endothelium, then what's going to happen? Well, I think you already know. What would happen is that these platelets would then start sticking to the endothelium. They would stick to one another via the GP2B3As. They would release ADP, thromboxane A2, and then eventually you would lead to this thrombus formation. And then after the thrombus formation, you'd have to activate the coagulation cascade, which will lead to the fibrin mesh. So the platelet plug is primary hemostasis and the fibrin mesh is secondary hemostasis. What I think is really important to remember here is that there's a couple different things that can increase the time, right, where platelets can bind. And I'd say the most common trigger for this is usually going to be immobilization. So this could be immobilization for a lot of different reasons, but anything that causes immobilization for long periods of time are going to increase the risk of stasis. This could be due to prolonged traveling, flights, car rides that are greater than 8 hours long, bed rest because you had a surgery, or bed rest for another reason. Maybe you have paralysis and you're not able to move. And so these are things that will definitely increase the risk of that contact time. Endothelial injury is whenever there is a reduction in your antithrombotic cytokines. And so you guys got to remember here that there's those cytokines which are called PGI2 and nitric oxide, right? So normally nitric oxide and PGI2 are supposed to do what? Well, they're supposed to basically inhibit the platelet from wanting to bind to the endothelium, right? That's what they normally do if this is present. But whenever there is dysfunction, there's damage to the endothelium, you lead to a decrease. So you inhibit the release of nitric oxide and prostacyclin. And as a result, guess what you're going to do? You're going to stimulate the platelets to start doing what? Aggregating to that site of injury. And when they do that, they're going to bind with the von Willebrand factor, they're going to bind with each other, they're going to release ADP, thromboxane A2, lead to the primary hemostasis. Coagulation cascade is going to be activated, and you're going to lead to the fibrin mesh, which is the secondary hemostasis. Question is what causes endothelial injury? A lot of different things. I'd say the most common one that is important to remember is some type of surgical procedure. So surgery is a really big one. Trauma is another one, right? I would also say smoking is a really big trigger for this as well. But you can understand that endothelial injury can be due to a lot of different things. But I would say some type of seizure, surgery, trauma, or smoking. Lastly is a hypercoagulable state. Hypercoagulable states, this can induce thrombosis, but it's interesting. It's usually due to an increase in the activity of procoagulants. So procoagulants, these are clotting factors that want to induce clotting. These are clotting factors that want to induce clotting, or it could also be due to a decrease in anticoagulants. And these are guys that want to stop clotting. All right? So they want to, again, do what? They want to, stop the bleeding process, the clotting process, right? So again, anticoagulants, you're trying to stop the clotting process. So if I have a hypercoagulable state, it could be due to an increase in procoagulants or a decrease in anticoagulants. Now, let's say here, in this particular scenario, I have the platelets, they aggregate, they form my primary hemostatic plug. When they form that primary hemostatic plug, if I have lots and lots of these procoagulants or less of these anticoagulants, my coagulation cascade is going to go ham, and I'm going to start leading to lots of these secondary hemostatic plugs forming. So we can see how in hypercoagulable states, this can definitely increase the risk of thrombosis because, again, you're increasing the activity of that secondary hemostatic plug. Now, when we talk about hypercoagulable states, it's important to remember that this could be inherited, right? And this is going to be the less common one, right? But it is something to think about, especially if you have a strong family history, you have recurrent thrombosis of like a DVT or a PE, or also like clots in weird locations, like cerebral veins, mesenteric veins, portal veins, hepatic veins, things like that. So that would be some things to consider, but it could be inherited thrombophilia, and we'll talk about what these are. Or it could be an acquired thrombophilia, right? Or it can be an acquired thrombophilia. And I'd say most of the cases, when we talk about this, it's usually going to be acquired. Now, when we kind of go back here, hypercoagulable state, you're hearing coagulants, procoagulants, anticoagulants, clotting factors. It's important to remember your clotting cascade. And again, this is a basic concept. You have your intrinsic pathway, which starts with factor 12. He becomes activated by binding to the negative charges on platelets. That then activates factor 11. Factor 11 activates factor 9. Factor 9 and activated factor 8, which is formed by thrombin, activating it, does what? Leads to factor 10. 10 and factor 5 activate thrombin, and thrombin converts fibrinogen into fibrin, all right? So this is that classic intrinsic pathway, right? And then these really help to drive this process. So when a patient is having some type of hypercoagulable state, maybe there's an increase in this activity where you're having some type of increase in this fibrin mesh being formed, right? You're making more fibrin mesh. You're causing more secondary hemostasis. It could be due to something going on with the intrinsic pathway. Maybe it's an increase in factor 5. Maybe it's an increase in factor 10. Who knows? Extrinsic pathway, it could be the same concept here. You have factor 3, which is tissue factor. It can get activated. And in the presence of that and factor 7A, these two can also activate factor 10. And so again, if a patient has some type of process here where they, for some reason, increase their tissue factor or increase their factor 7, they can increase the formation of the fibrin strands, right? And if you have more fibrin, you have more fibrin mesh, more platelet, secondary hemostatic plugs, you're going to get more thrombosis. So it is important to understand that we're having some way, shape, or form a process here. All right, but I want to dig into this a little bit more and kind of go step by step. So we know that a patient can get a thrombus from what reasons? Stasis of blood flow, that's usually due to immobilization for prolonged periods of time. Or it could be due to endothelial injury, smoking, surgical procedures, anything that's accessing and cutting into that vein or artery. That's going to be a problem. But the big one that we're trying to talk about today is hypercoagulable states. Increase in procoagulants and a decrease in anticoagulants. The big procoagulants, you're seeing them right here. It's factors 12, 11, 9, 8, 10, 5, and fibrin, right, which is the 1A, or factors 3 and 7. Your anticoagulants we'll talk about a little bit later, but these play a role in this pathway. Some of those that you'll probably want to mention a little bit later or know could be things like protein C, protein S, and antithrombin III. These are also involved in this. And these are in some way, there's an increase in the intrinsic activity, an increase in the extrinsic activity, and maybe there is a decrease in these proteins. And we'll dig into those specific diseases and see how that plays a role. But I'm just giving you kind of an introduction. So when we talk about hypercoagulable states, we said that they can be inherited, right? Inherited is really important to remember. And we'll talk about a couple of these, but again, we said it could be due to increased procoagulants, or it could be decreased anticoagulants. So if I have more procoagulants, which ones am I really kind of thinking about? Well, one of these conditions, we'll talk about this a little bit later, is called Factor V Leiden. That's one mutation. And this can be heterozygous or homozygous. Most of the time it's heterozygous, so it's not severe. But it is the most common hypercoagulable state that's inherited. The other one is a prothrombin gene mutation. So these are the big things that I would like you to remember that are primarily going to increase the activity of what we would say procoagulants. It's going to increase the activity of maybe the intrinsic or the extrinsic pathway and cause this type of process. The other one that could be inherited is a decrease in the activity of the anticoagulant pathways, right? And this could be due to things like protein C deficiency, protein S deficiency, as well as antithrombin III deficiency. So this is the really, really important things to remember here. So if we can kind of think about this, really what it comes down to is Factor V Leiden, if you go to this pathway, you're having an increased activity of Factor V. Prothrombin gene mutation, you're increasing the activity of thrombin formation. Protein C and protein S and antithrombin III deficiency, we'll see a little bit later, leads to inhibition of certain types of factors here, all right? And so if you have less of them, you can't inhibit these coagulation factors. So this is really important to remember. So we'll talk about these are the big ones. There's one other one that we'll mention very, very briefly, and that's hyperhomocystinemia, but these are the big inherited ones that I want you to think about. For acquired hypercoagulable states, this is going to be in a patient who doesn't really have a family history of such. We're thinking immune-mediated or non-immune-mediated. Now, non-immune-mediated is actually pretty straightforward, and this one, you want to think about pregnancy. That's a really, really big one. I would also consider things like oral contraceptives to kind of go hand in hand with that, because estrogen and progesterone have that ability to lead to this hypercoagulable state. Another one could be any kind of malignancy. That's definitely something I would also highly, highly consider. We'll talk about that. And when we talk about a lot of these, you'll see that there's so many different things that can contribute to this. We'll go over these a little bit later, but we'll talk about some rare entities in this particular scenario. We'll get into a little bit later, but there's some other ones like myeloproliferative neoplasia, which is an interesting one where you can have lots of red blood cells and lots of platelets, and that can increase your risk of forming these thromboses. But let's at least remember these right now. Now, when we talk about acquired hypercoagulable states, the most common reason is usually malignancy. So funny enough, if a patient has malignancy, that really increases the risk of a hypercoagulable state, much more so than these inherited thrombophilias and these immune-mediated ones. But when we talk about immune-mediated, this could be due to antibodies, and these antibodies could be activating procoagulants, or they could be activating platelets. And so if they activate or if they increase the activity of your procoagulants, or if they activate platelets, what's that going to do? I mean, think about it. Same thing like this, right? You increase your procoagulants, decrease your anticoagulants. What's your end game here? You're going to lead to a thrombus. Same thing. If you increase your procoagulants and activate your platelets, you're going to lead to a thrombus because you're causing the platelets to adhere to the endothelium, primary hemostatic plug, and you're causing the procoagulants to increase the activity to lead to fibrin, leading to the secondary hemostatic plug. So we got this all covered, right? It's pretty straightforward. Now, it could be autoantibody mediated, and we'll talk about a couple different conditions that could be due to autoantibodies. But in a rare select few, it can be due to complement proteins. And these complement proteins can maybe activate the platelets. And this is rare scenarios where C3 complements, we'll talk about it in what's called PNH, paroxysmal nocturnal hemoglobinuria, can lead to activated platelets and lead to a primary hemostatic plug. So with that being said, we've now discussed, okay, a patient who gets a thrombus, a DVT, a PE, those are the big ones, but maybe they get in weird locations in the cerebral sinus veins, or maybe they get in an hepatic vein, a splanchnic vein, a mesenteric vein, a hepatic vein, a portal vein. These are weird scenarios, right? Most of the time when a patient gets a DVT or PE, you think about, are they immobilized for some particular reason, right? Prolonged travel, bed rest, postoperative paralysis, or is there endothelial injury? Did they get a surgical procedure? Do they heavy smoke? Or hypercoagulable states. Especially in this one, you really want to be thinking about malignancy, pregnancy, oral contraceptives. Sometimes it can be immune mediated. I'd say that out of all of these, it's going to be one of those you don't always think about. And very rarely is it an inherited thrombophilia. But what I want to do now is I want to go through all the different types of inherited thrombophilias, explain how they lead to a procoagulable state, go through the types of immune-mediated thrombophilias and explain how they lead to a hypercoagulable state. And then the last thing I'll do is I'll discuss a couple little things about the malignancy aspect. And what I hope to accomplish throughout this conversation is how exactly do we differentiate them? Let's do that. All right, so let's talk about inherited thrombophilias. A patient comes in, maybe they have they have an episode of, I've had a DVT in 2001, 2004, 2010. So they've had recurrent DVTs or PEs. That's concerning for an inherited thrombophilia. That's one. Second, they come in and say, I got a family history. My father and his brother died at a young age due to a PE. Like maybe they were like 40. Usually less than 45 or 50 years of age with a strong family history of that first degree relative having a clot burden. That's enough to say it could be an inherited thrombophilia. Third is a patient who has clots, venous clots in very weird locations. Usually it's a DVT in the leg, right? It's usually going to be the big one, the femoral, the popliteal, the iliac vein, something like that. Or a PE. It's not common all the time to see cerebrovenous sinus thrombosis, especially hepatic vein thrombosis, mesenteric or portal vein thrombosis. That's not a common entity. So if you see those, you should think about an inherited thrombophilia, right? Those are three big reasons why I would consider that. Now, when you consider those, again, you want to think about Factor V Leiden mutation as the most common one. What happens in Factor V Leiden is that most of these patients have a heterozygous type of mutation, right? But what's really interesting here, and I think this is more of an MCQ for the step one, but they have some type of mutation where it's an R506Q mutation. And this just swaps out the amino acids in the protein of Factor V. And so what ends up happening is the liver makes this Factor V, right? Here it is. The difference is that now that you changed up the amino acids, you make this Factor V resistant to being degraded. So here you have protein C, and protein C is good at breaking down Factor V and Factor VIII, right? So this is an anticoagulant and wants to basically decrease the function of procoagulants. And so here's my Factor V. Protein C wants to degrade this, but what happens here is that this Factor V, imagine it like this. Imagine it's got like this little spike here. We'll kind of do it like this. And this is due to the change in the structure of Factor V. So because there was a mutation, you changed the structure. And now this protein C isn't able to go and degrade this. And so this reaction where you're supposed to degrade the Factor V doesn't occur. And so this leads to a increasing Factor V levels, and the reason is that it's due to protein C unable to degrade the Factor V. So this leads to protein C unable to degrade Factor V, right? And so because of that, that leads to these increased Factor V levels. What does Factor V help to do? It helps to, in combination with Factor X, do what? It leads to increase Factor II. Increased Factor II leads to increase fibrin formation. And if I increase my fibrin formation, what am I going to lead to? I'm going to lead to that secondary hemostatic plug, and boom, I got my thrombosis. So that's kind of how we see this kind of process play out, is we increase the amount of our Factor V by preventing it from being able to be degraded because of this mutation that exists. So if I cause that mutation changes the amino acid sequence, and it makes it to where protein C is now unable to degrade Factor V. It makes it resistant to degradation. Pretty interesting. Prothrombin gene mutation is another one. Now, this one is due to a mutation as well. This one is a mouthful. It's a G20210A mutation. And so I'm basically switching one of the nucleotides, right? Guanine for adenine, right? And so whenever you do this, you change the overall structure of the prothrombin, and you make it to where the prothrombin is more active. Now, in that scenario here, I'm going to lead to increased prothrombin, right? So this is going to lead to an increased prothrombin activity. Now that's interesting because prothrombin, right? Let's say here's our liver. Our liver makes this prothrombin. Prothrombin is basically factor 2. It's basically factor 2, but it's in the inactive form. And so what happens is if I have a prothrombin gene mutation, as long as I have the particular enzyme present, what will happen is I can convert the prothrombin into the active form. Because here thrombin, we need it to be in the active form technically. And so if I have high prothrombin activity, what I'm going to do is I'm going to convert that prothrombin into a lot of what? Thrombin. And if I get lots of thrombin, that's converted into eventually fibrinogen into fibrin. And if I get lots of fibrin, what am I going to do? I'm going to lead to my fibrin mesh. And I'm going to lead to this kind of clotting, this hypercoagulable state, right? So when we talk about Factor V Leiden, it's a Factor V that's resistant to the degradation of protein C, right? Due to a mutation changing the amino acid in the protein structure. For prothrombin gene mutation, I'm leading to a mutation where you switch a nucleotide that increases the expression of prothrombin. More prothrombin means you can make more thrombin, more fibrin, more clotting, okay? That increasing clotting or that thrombosis that we'll see will then present clinically in the form of a DVT, a PE, or unusual clot location. And in some circumstances, we can see these patients having pretty bad, recurrent thromboses. With hyperhomocystinemia, this one's kind of an interesting one. You don't see this a ton, but what we do consider this in is in patients who have, again, an inherited thrombophilia, and usually they present with arterial and venous clots. So it's a combination. Usually patients with Factor V Leiden, prothrombin gene mutation, antithrombin III, protein C, and S deficiency, they only really present with venous thrombosis. But hyperhomocystinemia is one of those rare types of inherited thrombophilias where a patient could present with both arterial and venous thrombosis. But this pathway is really dependent upon folate, actually. So you need folate in order to be converted into dihydrofolate, and then into tetrahydrofolate, then 5,10-methylene tetrahydrofolate, and then 5-methyl tetrahydrofolate. Now there's an enzyme that's really involved here, and this enzyme is called methyl tetrahydrofolate reductase. And it's supposed to drive this step, the conversion of 5,10-methylene to 5-methyl tetrahydrofolate. And the reason why that's important is 5-methyl tetrahydrofolate is needed in order for you to kind of do this particular process. So I want to go from 5-methyl tetrahydrofolate to tetrahydrofolate. So I want to give off a methyl group. And when I do that by another reaction, and I donate that methyl group to another molecule, and this molecule is called homocysteine. And I want to convert it to what's called methionine, which is a type of amino acid. But if a patient has a mutation, right? And so now they don't have the presence of this methyl tetrahydrofolate reductase. So now let's take this out and let's say that this person, if it's inherited, it is a mutation in the methyl tetrahydrofolate reductase enzyme. So now we're going to introduce this now. Ready? If I don't have the enzyme right here, I'm going to inhibit this step. I'll have less of this because, again, I don't have that methyl tetrahydrofolate. I have less of this. If I have less of this, I'm not going to be able to undergo this reaction. So this reaction will be inhibited. If this is inhibited, I'll make less of methionine and I'll build up homocysteine. Now, homocysteine is problematic because it's pro-inflammatory. And what it likes to do is it likes to activate Factor V, and it likes to activate It likes to suppress antithrombin III. So it'll increase the activity, or it'll stimulate factor V, and it will inhibit antithrombin III. So now, if I go ahead and I stimulate factor V, I'll increase what? That formation of factor II, thrombin. And then I'll increase the formation of fibrin. And if I increase the formation of fibrin, I'm going to lead to that fibrin mesh, baby. Yeah. Now, if I suppress or I inhibit antithrombin III, guess what antithrombin III does? It primarily decreases the production of thrombin. It's antithrombin. And so what will happen is I will do what? It naturally wants to suppress thrombin production. But if I inhibit antithrombin III, I will therefore decrease antithrombin III levels and I'll release it from inhibition. And so instead, I'll lead to the increased activity of thrombin and then the fibrin mesh. And then we'll get that thrombosis. So in patients who have hyperhomocystinemia, if it's inherited, it has to be due to a mutation here. In certain situations, it could be acquired, and this is usually in folate deficiency or B12 deficiency. But that's the big things to remember. So the next component here is, okay, we talked about Factor V Leiden, a basically hardy Factor V that can't be broken down by protein C, elevates the thrombin levels, the fibrin, you get a clot. Prothrombin G mutation, you get a mutation that leads to increased prothrombin activity, you get more thrombin, you get more fibrin, you get the fibrin mesh. Hyperhomocystinemia, a mutation in an enzyme that helps within the conversion of 5-methyltetrahydrofolate to tetrahydrofolate and homocysteine to methionine. You end up with increased homocysteine, you increase your factor V, you suppress your antithrombin III. This next one is protein C and S deficiency. So what's really important to remember is that the liver synthesizes what's called protein S. And protein S is really important because what happens is protein S is supposed to act as a cofactor. It's a cofactor, so let's write this down. It's a cofactor for protein C. So imagine this. If a patient has a deficiency in protein S, what will happen to the activity of protein C? I'll end up with decreased protein C. So if I have decreased protein S, I'll have decreased protein C. So you see how protein S deficiency is pretty much tied directly to the protein S deficiency. All right. So here's the important thing. If a patient has a protein S deficiency, they won't form protein C. If a patient has protein C deficiency, they just won't make protein C. So you get the difference here, right? So protein S deficiency, it's your liver's not making protein S and therefore you're not helping to activate protein C. Protein C deficiency, you're not producing protein C. Whenever there is a decrease in protein C is designed to inhibit procoagulants. So it wants to inhibit procoagulants. And this is going to be factor V and factor VIII. But if I have decreased protein C, am I going to be able to inhibit factor V and factor VIII? No. And so as a result, they stop becoming degraded and inhibited, and you increase their activity. Factor VIII and factor IX lead to the formation of factor X. Factor X and factor V combine and help to activate thrombin, right? And then thrombin leads to the formation of fibrin. So when you think about this, factor IX will really help to activate factor X, especially in the presence of, what's the other factor here that you would need? Factor IX. And then factor X and factor V will help to lead to the formation of thrombin. Thrombin will lead to the formation of fibrin. Fibrin will lead to that fibrin mesh. And therefore, you will get a thrombosis. So that's the big thing that I want you guys to remember here, okay? So I'm just trying to connect the dots here for you. So when a patient has Factor V Leiden, they have resistance to breakdown from protein C. If a patient has protein C and S deficiency, they can't break down Factor V and Factor VIII. So they go unregulated and increase clot formation. If a patient has a Prothrombin G mutation, they increase their prothrombin, they make more thrombin, more fibrin. If a patient has increase homocysteine, they suppress antithrombin III and increase factor V. So these are really, really important things to remember. So I'm going to end off with the last inherited one. The last inherited one here is antithrombin III deficiency. Now, really, really important thing to remember. Protein CNS deficiency and antithrombin III deficiency have these, like, I don't want to say pathognomonic, but close things that if you see this on the vignette, you gotta remember it. And I think this is really important to remember. If a patient has protein CNS deficiency, I would look at this in a patient who gets a patient with warfarin-induced skin necrosis. So you're probably like, wait, what? It's a really, really rough condition. The concept behind this is actually quite interesting, where for example, if a patient takes warfarin, if they take warfarin, what warfarin does is it acts on the vitamin K epoxide reductase enzyme present in the liver. And what happens is warfarin is supposed to produce, that vitamin K epoxide reductase enzyme is supposed to lead to the synthesis of factors 2, 7, 9, and 10, as well as protein C and S. If you take warfarin, you suppress that enzyme. If you suppress that enzyme, you decrease the production of all of these. So these levels fall and these levels fall. But because protein C and S have a very short half-life, they fall pretty quickly. What happens if you drop your protein C and protein S levels? You increase thrombosis. So in the first couple days, in the first like 3 to 5 days, until these levels start to kind of like drop, the patient's super hypercoagulable. So in the first 3 to 5 days, they are hypercoagulable. And this is normal. This is normal. That's why whenever you give warfarin, you try to bridge it with heparin. But now take into consideration, a patient has protein CNS deficiency. They're already deficient in protein CNS. You give them warfarin, and then guess what you do? You suppress their protein CNS down even more. They got none of this. They got no ability to basically inhibit factor V and factor VIII. These things go haywire, and they clot. And they end up with that skin necrosis, which looks a little bit like this. So it's really important to remember this high yield fact. With that being said, antithrombin III deficiency, when you see this one, it's usually almost always presented in the vignette where a patient has heparin resistance. So let me explain what that means. Patient comes in with a DVT, PE, you put them on heparin, and their PTT never gets to therapeutic levels. In other words, you never get that PTT to where you're basically kind of like within the range that you want to prevent them from getting that clot bigger and bigger and bigger. Because you're trying to prevent clot propagation with heparin. If I see them on super heavy, high doses of heparin and that PTT is not budging, definitely go thinking about antithrombin III deficiency. So that's really, really important to remember. So the liver makes antithrombin III, right? So if a patient has like cirrhosis, they can also have an acquired cause of antithrombin III deficiency. What's another disease that can actually, just as a side note, I'm not going to draw it up here, but if a patient has a urinary loss of antithrombin III, nephrotic syndrome, right? So nephrotic syndrome can actually cause antithrombin III deficiency and cause hypercoagulable states, and they get renal vein thrombosis. So that's another important one to remember. So write that down, nephrotic syndrome. But a really, really big thing here is, in a patient who has antithrombin III deficiency, they have a mutation that leads to a decreased production of antithrombin III. So I'm going to have decreased antithrombin III levels. Antithrombin III is primarily designed to be able to suppress the activity of what? Factors 9, factors 10, and the biggest one is thrombin. And so if you think about this, he's supposed to suppress all of these. All of these want, especially factor 10. So factor 9 and 8 will activate factor 10. Factor 10 and factor 5 will activate thrombin. But the biggest thing here is that thrombin, which is what? Factor 2 wants to do what? Activate fibrin. That's what it wants to do. And if you get that fibrin, you're gonna form that fibrin mesh, baby. And if you get that fibrin mesh, you're gonna get that secondary hemostatic plug, and you're gonna get that thrombosis. So that's the big thing here. So if I suppress antithrombin III, then what do? I no longer inhibit these factors. Instead, they'll become stimulated. Their activity will go up. And I'll increase the formation of fibrin. And again, these will both eventually lead to what? These will eventually lead to an increase in thrombin. I'm not going to go through the whole pathway, it's excessive at this point, but you get the point that antithrombin III deficiency does what? It basically works by suppressing thrombin. Normally, antithrombin III works by suppressing thrombin, factor 10, and factor 9. But if you have a deficiency in antithrombin III, you can no longer suppress them. They become activated and they increase clot formation. So now we can kind of see how patients become heparin resistant to antithrombin III deficiency. They're deficient in antithrombin III. What's heparin supposed to do? Heparin's supposed to increase antithrombin III, right? So we know that heparin is supposed to do what? Well, that puppy's an anticoagulant. It wants to increase the antithrombin III. That's what it wants to do. It wants to increase this, right? That's the normal mechanism. This is a normal mechanism of heparin. But guess what happens, right? This is the MOA, the mechanism of action of heparin. But in this scenario, guess what happens? You have deficient levels. So if you give heparin, it won't matter. It's not going to increase it enough to be able to get to the point where you can suppress these factors, and they're still going to have this thrombosis factor, or they're still going to have that PTT that just won't get where you want it to go. That's the big thing to remember for this. Okay, at this point we've covered the inherited types. When would you do this? Strong family history. First degree relative, less than 50, they got a DVT PE. Recurrent VTs, you've had 2, 3, 4 different DVTs or PEs, or you got a clot in an unusual location. Brain, hepatic vein, portal vein, mesenteric vein. Now that we've done that, let's talk about the acquired causes. All right, so now let's move on to the causes of acquired thrombophilia or an acquired hypercoagulable state. As I told you, most of the time it's malignancy. More often than not, that's going to be the biggest kind of trigger or risk factor for an acquired hypercoagulable state. But in some scenarios, it could be immune mediated, which we'll talk about as antiphospholipid syndrome, heparin-induced thrombocytopenia, and paroxysmal nocturnal hemoglobinuria. Another one that's acquired that's non-immune mediated besides malignancy is pregnancy and oral contraceptives. Again, don't forget those. But antiphospholipid syndrome is going to be one of those that they love to test. There's a couple different reasons why. One is that not only can they present with recurrent thrombosis, but they can present with recurrent spontaneous abortions. And that's because if you get thrombosis, if they occur in the placental vessels, you can thrombose the placental vessels. That can lead to placental infarctions, and then you lead to, unfortunately, a non-viable fetus because you're not able to supply the oxygen, the nutrients that you need to the fetus. So this can definitely lead to placental thrombosis, which can lead to, I'd say the biggest thing is greater than or equal to 3 spontaneous abortions at less than 10 weeks gestation. So usually in the first trimester, right? This is the big thing to remember. If it is one like unexplained spontaneous abortion greater than 10 weeks, you could also consider that for antiphospholipid syndrome. But this is the big thing to remember. So greater than or equal to 3 spontaneous abortions at less than 10 weeks gestation, think about antiphospholipid syndrome. Especially if they sometimes present with this weird like lacy type of appearance to their skin called livedo reticularis, which looks a little bit like this. So if I see that, I see recurrent spontaneous abortions or recurrent thrombosis, I'm going to think about this one. The other thing is antiphospholipid syndrome can occur primary, in other words, we don't have a great reason, or it could be secondary. And oftentimes this is commonly associated with what's called systemic lupus erythematosus. So it's most often seen with SLE. All right, so in this patient, they produce autoantibodies, right? They make these autoantibodies. So the plasma cells make these autoantibodies, and there's different types. One is called lupus anticoagulant. Another one is called anti-cardiolipin antibodies. And the last one is called anti-beta-2 glycoprotein. protein antibodies. Now, these antibodies are quite interesting. And the reason why I say that they're quite interesting is that they can do a couple different things. One of the things that these antibodies can do is that they can act on platelets. So they can stimulate these platelets. They can activate them. And if you activate these platelets, what is going to happen? These activated platelets are going to get consumed to make primary hemostatic plug. So now these platelets are going to be super activated. They're going to be consumed, and they're going to start going in here and binding onto the endothelial lining and leading to my primary hemostatic plug. That's one way. And this can actually lead to, if you activate the platelets and consume them enough, funny enough, this can actually lead to, potentially, if it's consumed enough, it could lead to thrombocytopenia. So definitely consider that in a patient who has thrombocytopenia. Think about antiphospholipid syndrome, especially if they have recurrent thrombosis or recurrent abortions. The other concept here is that these autoantibodies, they tend to act on the glycoproteins, particularly that are present within our anticoagulant activity. And so what they'll do is they will actually inhibit these particular proteins. And this is going to be things like Antithrombin III and protein C and S. So by doing that, think about this. If you inhibit antithrombin III, that's going to lead to what? You're not going to be able to suppress thrombin formation. You're not going to be able to suppress factor 10. You're not going to be able to suppress factor 9. If you decrease protein C and protein S, are you going to be able to inactivate factor 5 and factor 8? No. So what ends up happening with this is a terrible, terrible thing, which is I end up with an increase in a bunch of different things. One is thrombin. Next one is factor 5. Another one, factor 9, factor 10. So you see the whole problem here. And then also, I should have added this one in here before the 9, but 2, 5, 8, 9, and 10. And again, antithrombin III is supposed to suppress thrombin, factor 9, and factor 10. If you don't have that, you're going to end up with increased thrombin, increased factor 9, and increased factor 10. Protein C and S is supposed to suppress factor 5 and factor 8. If you don't have protein C or protein S, you'll lead to an increase in factor 5 and factor 8. By doing this, you're going to increase the formation of what? The common pathway leading to fibrin, and that fibrin is going to lead to that secondary hemostatic plug, which is going to lead to that fibrin mesh, and that's going to lead to your thrombosis. And that's going to occur in the veins, this can occur in arteries. So this is a really, really bad one, antiphospholipid syndrome. Now, it is important to remember that these antibodies, you need at least one of these to be positive, right? So I need at least one of these to be positive at least twice. So in other words, I have to check these antibodies. Let's say that I have a patient who comes in, they've had a bunch of abortions, they got clots, they got SLE, they got liver reticularis. I test the antibodies, one of them comes back positive. 12 weeks later, I gotta test it again to see if it comes back positive. If it does, and they have the laboratory and the clinical criteria, they meet the diagnosis of antiphospholipid syndrome. Another really important fact that they love to test for on the exam is lupus anticoagulant is an antibody. When you put it into a blood tube, so in vitro, and you actually look at this antibody, what it does is it actually causes the PTT to be prolonged. It acts like an anticoagulant. And so what has to happen is you would say, okay, cool. Well, the PTT is prolonged. What do you naturally do when PTTs are prolonged? You do a mixing study. You add in normal plasma and see if you're replacing whatever factors they're deficient in or if they have an inhibitor. So if you give them normal plasma, what will happen after a mixing study? Nothing, because they're not deficient, they have an inhibitor. So you'll have a no normalization. So if you do a mixing study, you'll have a increased PTT after a mixing study. So what do you truly have to do in order to see if that PTT normalizes? You have to add whatever these things like to bind to, phospholipids. So if you throw phospholipids into the test tube after you did the mixing study and it normalizes, that's also really suggestive of antiphospholipid syndrome. So adding that in there, if you take after the mixing study, you add some phospholipids to the mix. So let's say that I add in these phospholipids, then what that's going to do is that's going to cause the PTT to start to normalize. And that's super suggestive of antiphospholipid syndrome. All right. Now, anti-cardiolipin antibody, a really important point for this one, is that when you test patients who have antiphospholipid syndrome and this antibody comes back positive, if you also test them for syphilis, it can cause a false positive for syphilis. False positive for syphilis. Specifically like the RPR kind of testing. So false positive for syphilis. With this being said, antiphospholipid syndrome is the one that's going to be tested. The big things to remember: recurrent spontaneous abortions, at least greater than or equal to 3 of them, less than 10 weeks gestation. Also recurrent venous thrombosis that could be due to a DVT, a PE. You can even get arterial thrombosis if it's a catastrophic. And these patients, if they have that and they have one of these antibodies that are positive, twice at least 12 weeks apart, you meet the diagnosis. All right, that's the big things to take away from this. All right, the next one is heparin-induced thrombocytopenia. This one I don't want you to go too crazy about, but I really want you to think about this in a patient with heparin use, plus low platelets, plus thrombosis. And this one's bad, man. This one can occur in arteries or veins, just like in antiphospholipid syndrome. So what happens is you give the patient heparin. All right, so here's your heparin molecule in this pink. What heparin will do is, here's a platelet, and on the platelet there's a molecule here called PF4, platelet factor 4. Heparin will go and bind with platelet factor 4. And so now you get this complex. This is a heparin platelet factor 4 complex. This is kind of immunogenic. And so what happens is you have these antibodies against heparin and platelet factor 4. And what they do is they go and they bind onto that complex. When you do this, you activate the platelet. And so now that my platelets are activated, guess what I'm gonna do? I'm gonna consume the platelets to make thrombus. And so now I'm gonna consume these platelets, and these little puppies in here are gonna start binding on to the actual wall of the endothelium, leading to this primary hemostatic plug. Eventually the fibrin mesh will begin to form and I'll end up with a thrombosis. All right, so this is a patient who can get thrombosis, thrombocytopenia after heparin use within the past 5 to 15 days. All right, so antiphospholipid syndrome, female, young, SLE, recurrent spontaneous abortions, less than 10 weeks gestation, positive antibody testing, right, for the antiphospholipid antibodies. Heparin-induced thrombocytopenia, heparin exposure, thrombocytopenia, and thrombosis. All right, big thing here. Usually for this one, what we like to do is we like to first test what's called the PF4 antibodies. So we'll literally test these antibodies that are against the heparin and the PF4 and see if those are positive, especially if they have a high probability of having hit or heparin-induced thrombocytopenia. In other scenarios, what we can do is we can actually take these patients and do what's called a serotonin release assay, which we'll talk a little bit later in the diagnostic section. All right, but usually they'll have an elevated serotonin release because what happens is these autoantibodies are activating platelets, and what happens when you activate platelets? They release ADP, thromboxane A2, and serotonin. So if I'm activating them, I'm gonna have a high amount of serotonin. All right, we come down here. The next one is paroxysmal nocturnal hemoglobinuria. So this one, I really want you to think about this one in a patient who has dark urine in the morning, in the AM. I want you to think about this in a patient who has hemolysis. So how would I see if a patient has hemolysis? They would have an increased LDH, a decreased haptoglobin, some schistocytes, right? And then the other thing is I'd have odd locations for venous thromboembolism. What the heck does that mean? Cerebrovenous sinus thrombosis in the brain. I would end up with a portal vein thrombosis, hepatic vein thrombosis, just weird locations. So if they have dark urine in the morning, signs of hemolysis, and on top of that, unusual weird locations for a clot, think about PNH. Now, with PNH, I don't want to go too crazy because we talked about this in the anemia lecture. There is a PIG-A mutation. So there's a PIG-A gene that gets mutated. What happens is when you mutate that, it leads to a decreased expression of this protein. So now what happens is I don't produce this molecule here. I end up with a decrease in what's called the GPI anchor. That GPI anchor is supposed to bind these two proteins here, which is called CD55 and CD59. These are cluster differentiation proteins. If I don't have the anchor, can I bind onto these proteins? No. And if I can't bind onto these proteins, do I have enough of these? No. You know what these proteins are supposed to do? They're supposed to inhibit complements. If I don't have them, can I inhibit the complements? No. So what happens? I activate them sons of guns. So now the C3 complements are activated. And these sons of guns, these little SOBs are relentless. And what happens is, when these become activated, they go and they bind on to the red blood cell. And they trigger hemolysis of the red blood cell. All right, so they trigger a complement-mediated hemolysis. They cause the membrane attack complexes, right? Then what happens is, what's the most primary molecule found inside of red blood cells? Hemoglobin. So what gets released? Hemoglobin. That hemoglobin gets released into the bloodstream. When you get a lot of hemoglobin into the bloodstream, guess what it binds to? Nitric oxide. When you bind up nitric oxide, what happens to the free circulating nitric oxide? It decreases. So you decrease the free nitric oxide. Why is that important? If you decrease the free nitric oxide, guess what nitric oxide is supposed to do? You guys remember this? In a normal endothelial cell, it releases what's called PGI2 and nitric oxide, which does what? It inhibits the platelets. It's supposed to suppress them. Right? It's supposed to suppress them and prevent them from being activated. But if you have less nitric oxide, what happens? If I don't have enough of this, I'm going to stimulate the platelets. And then what's going to happen? Oh man, I got activated platelets, baby. My platelets are super activated. And if I get these activated platelets in the right area, guess what they're going to do? They're going to fuck my stuff up. They're going to come in here and they're going to start causing that primary hemostatic plug. And they're going to lead to a good thrombosis in an odd, unusual location. And that's the big difference. So they'll get hemolysis, and that's where you'll get all the increased LDH, right? So that's where you get the increased LDH, the decreased haptoglobin, right? So the increased LDH, the decreased haptoglobin, and then the schistocytes, right? Because you're busting these things open, right? But the big thing to really take away here is the mechanism by how we actually cause thrombosis. All right, that's this one. The next one is malignancy. So we can actually see this in two different types of malignancies. One is called myeloproliferative neoplasia, and one is just your solid organ. So one is like a solid organ malignancy, and this other one is called myeloproliferative neoplasia. This is a type of like hematologic malignancy, essentially. Now, solid organ malignancies, they're actually a lot easier. Usually, for example, if a patient has lung cancer, or if they have something like pancreatic cancer, especially adenocarcinoma, let's actually write that down, adenocarcinoma. These carcinomas, funny enough, have the ability to secrete tissue factor. What's tissue factor? Factor 3. And so if they increase the expression of factor 3, guess what happens? Factor 3 and then combination with factor 7 lead to factor 10. Factor 10 and factor 5 lead to factor 2. Factor 2 converts 1 into 1A. And then what do I get? I get my fibrin mesh. So these two will combine to activate factor 10. These will combine to activate factor 2. Fix this up a little bit. And then factor 2 will convert factors 1 into 1A, which then this leads to that beautiful, what? We'll already have the platelet plug. What will this help with? This will help with the fibrin mesh. All right? So that's the big thing here. So when a patient has pancreatic adenocarcinoma, big thing to look for is the patient with abdominal pain, right? Maybe some nausea. But you know what else they like to do? They like to test the CA19-9, kind of like tumor marker. But another thing that they like to do is they like to look for what's called migratory superficial thrombophlebitis, these red inflamed veins that you can see appearing on their arms. All right, that's one thing. Lung cancer, look for specific signs: cough, shortness of breath, hemoptysis, things of that nature. All right, and it's really important to remember this because we like to do age-appropriate cancer screening in a patient who has recurrent thromboses and we haven't found an inherited or other type of acquired cause. You really want to think about maybe a chest X-ray or a CT scan. Now, with myeloproliferative neoplasia, these are weird. So you have like a myeloid stem cell, and these are supposed to help to make a bunch of different cells. One is red blood cells, another one's platelets. If a patient experiences what's called a JAK2 mutation, so they have a JAK2 mutation, this mutation will lead to a hyperproliferative state. Then what's going to happen is I'm going to stimulate proliferation. I'm going to increase the proliferation of that myeloid cell line of cells. And so what's going to happen is, man, this bone marrow is going to be pumping out red cells or pumping out platelets. And so what's it called when you have lots of red blood cells? Polycythemia. And if it's due to a bone marrow problem, it's called polycythemia vera. And if you have lots of platelets, it's called thrombocytosis. But if it's due to a problem with the bone marrow, where it's actually a mutation in this scenario, it's called essential thrombocythemia. Now, in these scenarios, we consider these to be a myeloproliferative neoplasia. Now, this one, polycythemia vera, will increase the viscosity of the blood. And that just predisposes it to sludging up the blood and definitely increasing the risk of thrombosis. Not via the mechanisms that we've talked about, funny enough, but it does increase viscosity, which can increase thrombosis. Essential thrombocythemia, that basically increases the number of platelets, which can also increase the viscosity. But if I increase the viscosity there, that can definitely cause this. But also I have more platelets that can potentially precipitate a platelet plug formation. Either way, I'm getting thrombosis. So when I talk about these, the way that I want you to start forming frameworks with a thrombophilia or hypercoagulable patient is they have DVTs or PEs that are recurrent. They have recurrent spontaneous abortions. They have a strong family history of a family member who's young who's had these clots. Or they have, again, clots in unusual locations. Is it inherited? Is that the case? Check for protein C, S, Factor V, Antithrombin III, and again, check for that Prothrombin G mutation. Big things to remember for the high yield. For antithrombin III, look for a patient who's not responding to heparin. They're resistant to it. For protein C and S deficiency, look for a patient who gets put on warfarin and they get really bad skin necrosis. For antiphospholipid syndrome, look for recurrent spontaneous abortions. But again, you need to have at least 2 times where these antibodies that we talked about are positive. For all of these other ones, they can be present, but the most common one in true clinical reality is going to be malignancy. This increases the risk of hypercoagulability so many-fold. So really remember these. All right, we talked a lot about this stuff. Let's now move into what are the potential presentation or complications of a hypercoagulable state. All right, so we've talked a lot about the pathophysiology of hypercoagulable states. What are the big ways that these patients will present? So the biggest complications is the thrombosis itself, but it can occur in veins and it can occur in arteries and veins. It's important to remember, especially in the clinical vignette, which one tends to predispose more towards the veins and which ones can involve both and how these will actually look. So more common than not, you'll have a clot in some type of deep vein in the leg. That's usually called a DVT. Look for pain, swelling, and asymmetrical swelling at that, usually of a lower extremity. And if you can, you get that positive Hohmann sign when you dorsiflex. Another one is that DVT could break off. And if it breaks off, it could move into the right atrium, the right ventricle, and it can get stuck inside of a pulmonary artery. And that is called a pulmonary embolism. For this, if a patient gets a PE, a pulmonary embolism, you want to look for tachycardia, tachypnea, you want to look for any evidence of dyspnea. increased work of breathing, and I would even look for episodes of hypoxia as well. The next thing is, and this is the unusual locations, is a clot somewhere within like a cerebral sinus vein. And so this is called cerebral venous sinus thrombosis. For this, you really want to watch out because this can actually cause a really, really bad headache. It can even cause seizures because it can irritate the cortex. Sometimes they can hemorrhage or it can cause a stroke. And a big thing is it'll cause a lot of increased ICP. And so you can see potential intracranial hypertension features as well. The next one is you can get a clot inside of the hepatic vein, and this is called Budd-Chiari syndrome. All right. Definitely when you hear this, you should think about something like the polycythemia vera, essential thrombocythemia, paroxysmal nocturnal hemoglobinuria, right? Things of that nature. The other one is it can occur in the portal vein. So this is called portal vein thrombosis. And then here you could get a mesenteric, that's the splenic vein. You don't usually get that one there. But you can also get a inferior mesenteric or superior mesenteric vein thrombosis. And so I would definitely be on the lookout for some type of mesenteric thrombosis. Budd-Chiari syndrome, which is a hepatic vein thrombosis, usually that will present with right upper quadrant pain, right? You may even develop some hepatomegaly, some increased LFTs. Portal vein thrombosis will lead to portal hypertension. So it'll lead to splenomegaly, it'll lead to ascites, it can lead to potentially esophageal varices, and it also can lead to a lot of problems such as, again, swelling of some of the venous structures. So it can lead to a worst case scenario, it can potentially lead to a bowel obstruction via bowel wall edema. And then mesenteric thrombosis, especially if it's an acute one, this can actually cause acute ischemic necrosis of the bowel. So acute mesenteric ischemia. And so these are really, really important things to remember. So pain out of proportion with an elevated lactate level, maybe even a risk of bowel perforation and sepsis is big with this one. So if a patient comes in, more often than not, it's going to be a DVT or it's going to be a PE. Rarely will it be a cerebral venous sinus thrombosis or these abdominal vein thrombosis. But if it is, the more common ones to see that are going to be associated with primarily venous thrombosis on its own, it is worth remembering that it's going to be Factor V Leiden, it's going to be Prothrombin, gene mutation, it's going to be protein C and S deficiency, and it's going to be Antithrombin III deficiency. Antithrombin III deficiency. So if a patient has recurrent venous thrombosis only, you really want to think about these. But if a patient has arterial and venous thrombosis, so in other words, not only do they have a DVT history, a PE history, maybe not just a cerebrovenous sinus thrombosis, mesenteric portal, hepatic vein thrombosis, but they can have arterial thrombosis. Maybe you have a coronary artery and they can develop a MI. Or of a carotid artery and they can develop a CVA. So they can end up blocking off the blood flow to the brain. Or of the lower limb. And so this can lead to acute limb ischemia. And so really watch out for myocardial ischemia or infarction, cerebrovascular accident, and acute limb ischemia. And again, it's not just arterial, it's arterial and venous, so they can get both of these. Which ones most commonly cause both presentations? In that scenario, you think about the acquired ones. So you think about antiphospholipid syndrome. The next one is I would think about paroxysmal nocturnal hemoglobinuria and HIT. I would also definitely be considering one other inherited type. The other inherited type here would definitely be the hyperhomocystinemia. And the last thing is malignancy. With all of that being said, you're noticing a trend that most of the causes that lead to arterial and venous is the acquired causes, with the exception of hyperhomocystinemia. And the ones that primarily lead to venous clots are going to be the inherited ones, except for hyperhomocystinemia. Again, I would add one little exception, and it's remember that PNH And malignancies, especially because we're talking about a couple different ones here. This could be the MPN, the myeloproliferative neoplasia, as well as solid organ. The MPNs and PNH cause these types of weird clots. So in these weird, unusual clots, definitely don't forget about this one, and definitely don't forget about this one. All right? All right. Patient comes in with a thrombus. You have to discern if it's primarily venous or if there's venous and arterial. From there, once you've determined that there is a thrombus, if there is a recurrent thrombosis, recurrent spontaneous abortions, strong family history of thrombosis at a young age, or clots in unusual locations, work up the patient for thrombophilia. Do the inherited panel, which we talked about here, with the exception of this, and then work up the acquired causes, especially in certain types of risk factors: antiphospholipid syndrome, PNH, HIT, and malignancy. All right, let's talk about the diagnostic approach. Let's say that you have a patient coming in and you want to determine if they should get screened for a thrombophilia, whether it's an inherited or it's an acquired. These are the things that you need to remember. They have to have an unprovoked clot at a young age. So if they have a DVT or a PE and they're less than 50 and they have no risk factors for stasis, no risk factors for endothelial injury, then you can consider testing them. Another one is recurrent clots. If a patient came in, they had a DVT, a year later they have another DVT, a year later after that they had a PE, you should definitely be testing them for an inherited or acquired thrombophilia. If they have thrombosis in really weird locations that normally should not happen with stasis, that should normally not happen with endothelial injury, if that is happening, you really want to think about malignancy, you really want to think about paroxysmal nocturnal hemoglobinuria, you really want to think about some of these hypercoagulable states, all right? Recurrent spontaneous abortions, this is actually really important because this is actually placental artery thrombosis. So what happens is you get clots that form within the placental arteries, and that leads to placental insufficiency. And then that's why these patients have spontaneous abortions. If you hear that, again, remember antiphospholipid syndrome. And a strong family history. If a patient can state, my mother had a DVT or a PE at 30, or they had recurrent DVTs or PEs, or they had a stroke at a young age, you can start thinking about these hypercoagulable states, all right? Now, you'll get an inherited thrombophilia panel. You'll check their Factor V, right? You'll check their prothrombin, you'll check the protein C, S, antithrombin III, you'll check their homocysteine levels. All of those things will happen. It's just you have to be careful. You really can't be screening for thrombophilia if a patient has an acute thrombosis or they're on anticoagulation, because it can skew the results. The only exceptions to this is really just Factor V Leiden and Prothrombin G mutation. These are the only two that you can truly test when a patient has an acute thrombosis or they're on anticoagulation. So you actually have to wait until that resolves, and then you can test them for these particular thrombophilias, all right? It's actually quite interesting when you look at the risk of people who have like DVTs or PEs and them having an inherited thrombophilia. It is such a small percentage. And so it's really important to know that we don't want to expose the patient to unnecessary testing if they don't need it. All right. So unprovoked, recurrent, weird clots, recurrent spontaneous abortions, and a strong family history. Get an inherited thrombophilia panel. The only time you should actually say, maybe I should wait, is if they have acute thrombosis or are on anticoagulation. The only diseases that if you likely think that they could actually have is Factor V Leiden and Prothrombin G mutation. So the only ones that if you do the testing, they're the only ones that if it came back positive, it would be accurate. All right. If you get a positive inherited thrombophilia panel, it's just a matter of which part of that was positive. All right. So if I told you that they have a decreased what's called activated protein C sensitivity, what would that mean? Oh, okay, that would be Factor V Leiden. Oh, I remember why. Because in Factor V Leiden, the protein C couldn't break down the Factor V. That's why it's important. If I see G20210A mutation on the PCR, you think Prothrombin G mutation. If I have hyperhomocystinemia, boom. If I have decreased protein C activity, protein C deficiency, decreased protein S activity, protein S deficiency, and decreased antithrombin III activity, antithrombin III deficiency. So these right here are pretty simple. It's just a matter of remembering that this is the specific thing that we're looking for. We're not actually looking for increased Factor V levels. We're looking at activated protein C sensitivity. It's going to be low in Factor V Leiden, and you're going to look for the specific G20210A mutation for Prothrombin G mutation. Now, if I don't have a positive inherited thrombophilia panel, I could still have an acquired one, right? So that's when I want to test for the most common one, which is the antiphospholipid syndrome. So I'm going to get that antiphospholipid antibody panel. You guys remember which one it was? Again, you got to do these where you check the antibody studies. And again, you got to have at least one of the three on these on 2 occasions, 12 weeks apart. Really, really important. You have to have positive antibodies for at least one of them. All right, one of those 3 on 2 occasions, 12 weeks apart to truly make the diagnosis. So you're looking for the lupus anticoagulant, you're looking for the anticardiolipin, or you're looking for the anti-beta-2 glycoprotein antibodies to be positive. If you get at least one of those 3 positive 2 times, 12 weeks apart, and you have the potential screening criteria already where they had recurrent spontaneous abortions or VTEs, all right, you probably got antiphospholipid syndrome, all right? The other thing that I would say that is more miscellaneous testing, if you come up with a negative inherited thrombophilia panel and you get the antiphospholipid antibody panel, is look at the patient's history to see if you would do other testing. So for example, if I had a patient who had heparin use and they have thrombocytopenia and they have clots, I would get a PF4 antibody and a serotonin release assay to confirm HIT. If I have a suspicion of paroxysmal nocturnal hemoglobinuria, dark urine in the morning, hemolysis, then I may get a flow cytometry to look for that decreased CD55 and FIT59. If I have a suspicion of MPN because they have really high hemoglobin, like in polycythemia vera, or really high platelet count, such as an essential thrombocythemia, I'd get a JAK2 mutation on their PCR and see if that comes back positive. And if I have a suspicion of occult malignancy, this is really, really important, then I would do an age-appropriate cancer screening. Chest x-ray to look for lung cancer, CT abdomen pelvis to look for a potential pancreatic adenocarcinoma, okay? All right, so when we talk about treatment here, we really have determined, okay, does the patient have an inherited or an acquired thrombophilia? I've done that based upon the screening to know when I should test for it. I know when I should really be careful to not really interpret the results as being accurate if they're on anticoagulation or if they have an acute thrombosis. There's 2 exceptions. I can know which one is positive based upon the results of that thrombophilia panel. If it's a negative inherited thrombophilia panel, I want to test for antiphospholipid syndrome. And based upon their history in the clinical vignette, I'll know when I'll test for other potential miscellaneous causes. So treatment here really depends upon if the patient has thrombosis or not. If they have an acute thrombosis, you have to manage that. And that's usually initiating anticoagulation. Usually this is dependent upon the patient having HIT or not, which one you'll determine. If the patient has HIT, which is a type of hypercoagulable state, you don't give classic medications that you would give, which is heparin. In this one, you give the non-common medications that we don't often utilize, which is your IV direct thrombin inhibitors. This is argatroban or bivalirudin. If they don't have HIT as their cause of thrombosis, then you give them heparin. Usually it's low molecular weight is the common one, or unfractionated heparin, which is usually given in a drip. Now, if they have a thrombophilia, the next component here is, do we initiate long-term management for this patient? So we'll get them started to help actually prevent the clot from propagating. So we'll start them on either heparin or argatroban. Then from there, we may have to continue anticoagulation outpatient for about 3 to 6 months. And then maybe some patients, you have to continue anticoagulation for the rest of their life. The long-term management depends upon the underlying type of thrombophilia. For an inherited thrombophilia, you can do a DOAC, so your direct oral anticoagulants. This could be dabigatran, which is your thrombin inhibitor, or you can do your factor X inhibitors, which is going to be your apixaban or rivaroxaban. You could also consider warfarin, really just whichever option is best. For antiphospholipid syndrome, that one is explicitly warfarin. All right, has to be warfarin for this one. For malignancy, we actually prefer low molecular weight heparin if we can. And then for PNH or MPNs, this is actually a problem with an immune issue. We actually have to address the immune process or the malignancy process. And so we either need to give something to kind of suppress this or suppress this. So what we actually do is we say, let's suppress them. And if they have PNH, we actually give them something called eculizumab. And eculizumab is actually going to inhibit that complement-mediated hemolysis and that spilling out of hemoglobin. And that's going to help to reduce the future thrombosis. For MPNs, though, we want to shut down the bone marrow. And we want to tell the bone marrow to stop producing tons of red cells and producing tons of platelets. And so that's when we use something like hydroxyurea. All right? Now, it's important to remember that when you put a patient on any kind of anticoagulation, you may need specific monitoring parameters. For example, if I have them on argatroban or bivalirudin, I got to monitor the PTT to see if I'm within range. Heparin, we like to monitor PTT. There's actually a lot of literature that is supporting utilizing anti-XA levels or 10A levels a little bit more now because they're more accurate. DOACs, we don't really usually routinely monitor these at all, which makes them attractive for long-term management. But warfarin, we need to monitor the INR, and depending upon what their underlying problem is, you may need to aim for 2 to 3 if they have no mechanical valve, or 2.5 to 3.5 if they have a mechanical valve. And sometimes with antiphospholipid syndrome, we actually may aim for that 2.5 to 3.5 a little bit. So these are really, really important things to remember. Now, to put into perspective how these actual drugs really work, things like heparin and direct thrombin and direct factor X inhibitors and all of these drugs work, we actually have to talk a little bit about the coagulation pathways. You remember the intrinsic pathways. You activate factor 12, then 11, then 9, and then 8. And that's going to eventually do what? Convert 10 into 10A. And then you have your extrinsic pathway, which is factors 3 and 7, which are going to help to convert 10 into 10A. And then 10A combines with 5, and that actually helps to convert prothrombin into thrombin. And then thrombin converts fibrinogen into fibrin. And then fibrin is really what helps to cross-link whenever factor 13 is present to really make a nice stable fibrin mesh that gives you a good secondary hemostatic plug. So when we talk about these drugs, things like, for example, heparin, well, heparin is really great because there's a couple different types that we talked about. Unfractionated, that's the IV, the one that we titrate very, very carefully off of a PTT. Or low molecular weight heparin, which is usually a subcutaneous injection twice daily. And that one we can do more likely an anti-XA level, but we really only prefer to do this if a patient has severe obesity or renal failure, because those are times where it may not be cleared from the kidney as well. We don't often use this one, but it can be considered, especially sometimes in HIT, funny enough, is fondaparinux. It's a synthetic type of heparin. But basically what these are doing is they're increasing antithrombin III levels. Antithrombin III, the most potent one, is it really likes to inhibit factor 10, but unfractionated heparin only can really suppress thrombin. And that's really important to remember. And so if you suppress these, guess what? You're suppressing this whole downward cascade, and you're gonna inhibit that secondary hemostasis, right? With direct thrombin inhibitors, again, there's IV and then there's oral. The IV ones are the ones that we use in HIT, right? That's argatroban and bivalirudin. And really what they're doing is they're just an alternative to heparin if the patient has HIT. All they do, it's pretty simple. They just inhibit thrombin, which again inhibits this whole downward cascade, and you don't get secondary hemostasis that occurs. If we look at the long-term management of thrombosis, again, we get to the DOACs or warfarin. Again, DOACs include direct thrombin inhibitors or direct factor X inhibitors. The oral ones are usually going to be what? It's dabigatran. And again, that's really just going to do the same thing. It's going to inhibit thrombin. It's going to inhibit that downward cascade. With direct 10A inhibitors, like apixaban or rivaroxaban, it's just directly inhibiting this puppy right here. And again, you're going to suppress this downward cascade, right? And if I suppress that, I'm not going to get my cross-link fibrin. I'm going to inhibit my secondary hemostasis. Warfarin's a beautiful one in the sense that it really acts against the vitamin K epoxide reductase, which converts this oxidized vitamin K to the reduced one. So there's an enzyme that helps to really process that. And then we actually can go back from the reduced to the oxidized to continue this cycle with an enzyme called GGT. So whenever you give something like that, it's really important because warfarin is going to actually work again in this particular process where vitamin K goes into the oxidized to reduced form. And then whenever it goes back into the oxidized form, the GGT utilizes that vitamin K to convert the 2, 7, 9, and 10 into the functional components, which if those are there, they can actually cause thrombosis, right? When you give warfarin, it actually inhibits the vitamin K epoxide reductase. That inhibits this step. You get less reduced vitamin K. Less of it can go back to the oxidized form. So you inhibit the GGT from being able to convert these into functional 2, 7, 9, and 10. If I can't make these dang things, then what's going to happen? I'm not going to be able to produce thrombosis. But what's important is that all of these, the one that actually decreases the quickest, which is why we monitor PT-INR for these patients, is factor 7. Because factor 7 is really a monitor of the extrinsic pathway, which we use PT-INR here, and for intrinsic we use PTT. So that explains that a little bit. All right. But again, if you decrease all of these, dude, you're going to really shut down the fibrin pathway, and you're really going to inhibit cross-link fibrin, and you're going to inhibit secondary hemostasis. So these are how these drugs are working. So it's pretty self-explanatory how they work. The only one that involves a little bit more explanation is the warfarin. It inhibits the reduction of vitamin K, and if you can't get the reduced vitamin K, you can't convert it back into the oxidized, which is needed to make functional 2, 7, 9, and 10. If you can't make these, you can't actually trigger this pathway at all. The one that usually drops first, and so it's the most likely to be monitored with the PT-INR, is factor 7 though. All right. My friends, that covers hypercoagulable states. I really hope that you guys enjoyed. I hope you learned a lot, and I hope it made sense. And love you guys. Thank you guys. And as always, until next time.